Coming up in this episode, technology and COVID-19, the impact to the healthcare industry. How has COVID-19 changed the economics of healthcare? What is the impact of those changes on cybersecurity and compliance? This is the Go Beyond Disruption podcast, and those are just some of the topics we'll be exploring in this Cybersecurity Advisory. Welcome to the Go Beyond Disruption podcast, brought to you by the Association of International Certified Professional Accountants, the unified voice of the AICPA and CIMA. Every week, we share insights from inside the accounting and finance profession that help you stay ahead of the curve, whatever business you're in. In the hosting seat this week, I'm Jeff Krull, partner with Baker Tilly US in the United States, based in Philadelphia. I lead Baker Tilly's cybersecurity practice and spend a significant portion of my time performing HIPAA-related and compliance assessments. Our topic this week is technology and COVID-19 and the impact to the healthcare industry. We will be discussing how COVID-19 has impacted the economics of the healthcare industry and the use of technology, what the long-term implications may be of that impact, and the potential impact of the technology changes from a security and HIPAA perspective. Before we get into the discussion, let's meet each of our panel members. Bert, let's start with you.
Good afternoon, and thank you, Jeff. My name is Bert Orlov. I am Managing Director of the Healthcare Consulting Group within Eisner Amper. We are based in the East Coast of New York, and we work across the United States, but not internationally. I am in charge of the strategy and business development practice, as well as our government services practice. So I tend to take a big picture view of the topics that we're going to discuss.
Thank you, Bert. And thank you, Jeff. Hi, this is Stephen Bisciello. I am also with Eisner Amper's Healthcare Consulting Group. I am a director here in the group, a colleague of Bert Orlov's, located here in New York City, and I lead the Revenue Cycle Management and Operations Service line. I'm very pleased to be here and to participate in today's conversation. And a lot of my work focuses on the operationalizing, day-to-day, in-the-weeds details.
And hello, everyone, and thank you, Jeff. It's a pleasure to be with you today. My name is Jerry Ravi. I am also at Eisner Amper. I'm a partner, and I lead the firm-wide services around process risk and technology solutions. Really a pleasure to be here with my colleagues, Bert and Stephen, as well. We work closely together on a lot of healthcare-related topics and the risks associated with what I would call my role on this podcast, which is cybersecurity. So specializing in process risk and technology solutions means a lot of things, but in essence, what I want to focus on today is really a bit different than Bert and Stephen's, but although it's complementary, providing peace of mind, as I call it, around those risks and opportunities, because I think this time that we're in poses a lot of risks, and I'll be focused on what those cybersecurity challenges and solutions are, but they also bring opportunities into the marketplace and things to think about. And I'll be discussing that as part of my role. And when we talk about things like patient outcome or patient engagement, I'll be bringing that up along with a number of other things that we can probably see as challenges as we come up.
Let's jump into today's topic. Bert, COVID-19 created short-term devastation to the economics of many healthcare providers. Walk us through what's happening from a demand function and economics viewpoint due to COVID.
My pleasure, Jeff. As most of you are aware, the pandemic has caused a dramatic decline in volumes for physicians and hospital practices. That drop in utilization has been dramatic in the United States. ED visits, for example, have gone down 42%. Office visits have gone down by 90%. Surgeries by 70%. So we are in an anomalous market. We think the real question today is, what is the rebound going to look like, and will it be enough for hospitals and physician practices to return to operations status quo ante? We, of course, don't know with certainty, but what we are seeing is that, and I'm citing a Commonwealth Fund study here, is that the rebound has only been about 2/3 of the quote normal pre-COVID numbers. Telemedicine, however, tells us a different story, in part because the demand for telehealth as a supplement to traditional on-site in-person care has risen dramatically. For example, the Centers for Medicare and Medicaid Services here in the U.S. have seen an 8,000% increase in use of telehealth services. Epic, a major healthcare systems operator, has shown that in July, telehealth continued to account for over 20%, which is dramatically greater than previously, but down substantially from 70% in, let's say, March. That has, of course, great strategic implications for our clients as to how to manage and how to balance. And Stephen has to face the challenge of operationalizing that strategic agility. Stephen?
Thank you, Bert. Much appreciated. I think the best way to kind of describe this is to give a real world scenario. So our healthcare consulting group, in our revenue cycle management and operations service line, we have the privilege to provide, in certain cases, interim management for our clients, both large and small. One of such, we were brought in to perform interim management due to some turnover in the administrative leadership. And this project began before COVID hit. We immediately had to change our specific focus as COVID hit for a number of reasons. One, this specific practice was forced, due to COVID, to significantly shift their focus from, as Bert described, traditional medicine, and had to immediately implement and operationalize a telehealth supplemental service line. They were required to make this change due to the elective surgical cancellation, as well as reduced in-office visits, given their geographic location. So we saw firsthand during this interim management how the demand for telemedicine was required to not only treat patients for the continuum of care, but also in this case, and as well as in a lot of cases for our other clients, for practice survival. So what compounded the demand was telemedicine was previously not performed in this practice, as some other practices of ours, as Bert alluded to, have had telemedicine as a quote-unquote supplement, but not their leading charge. So there was no telehealth pre-COVID, and we were forced to fast forward the implementation and operationalize the implementation of telehealth immediately over a period of 30 days. And I will talk a little bit later on the actual steps that we had to put into place while in fast forward mode.
So, Bert, what do you think this means from the standpoint of the telehealth marketplace?
I'm going to answer in a couple pieces. First is I'm going to note that anything we're talking about here technologically is applicable globally. However, I'm also going to be talking about the regulatory environment in the United States, which is unique to the United States. Now, the broad background for telehealth is that we in the industry have been anticipating the explosion of telehealth for years now. And it's been growing slowly. But then in February, COVID hit and our predictions finally came true. And I'll give you an example. A firm, Teladoc, a major telehealth provider in the U.S., has seen 70% growth year over year, up to 200,000 virtual visits a day. The University of California Health System went from 100 video encounters a week before March of 2020 to around 3,000 a day. It gives you a sense of the scope of the change. Part of what's facilitated that is not so much new technology, but regulatory responses in the U.S. The government opened wide the doors for use of telehealth, relaxed a lot of the historical restrictions, and that enabled a quick transition, but that transition isn't necessarily complete. And so that drives to the question, so what is the future? Clearly, telehealth is here to stay. Many patients like it. It has certain advantages and it applies well in certain areas. It's great for providing access to health to rural populations. It can be very powerful for chronic care monitoring. It brings in the new focus of mental health, behavioral health services. But what we don't know is the extent to which the regulatory environment will stay as friendly to telehealth. It can't go all the way back. Bipartisan Senate and House leadership in the U.S. have made clear a commitment to advance continued looser regulatory framework for telehealth. And in general, in the U.S., private insurers tend to follow the policy direction of Medicare. That said, we have to move, or rather, Stephen will talk about how we have to help our clients move from a sort of temporary ad hoc approach to telehealth to a more structured one with its distinct needs for coding, documentation, HIPAA security, protected communication, special concerns about privacy, etc. And that is a critical area that I think Stephen was alluding to before. And Stephen, why don't you elaborate on some of those challenges we're seeing?
Sure, will do. Thank you, Bert. So, for anybody that's in the marketplace, either working within industry or working as a consultant, if you've ever added any new technology or process to any healthcare organization or operation, there is typically a number of months involved for onboarding, training, Q&A, and then working out any technological and process bugs, and then moving more towards optimization. With telehealth, the operational steps required affect multiple aspects of your healthcare organization, physician practice, hospital, what have you. It affects, obviously, technology. It affects multiple operational and revenue cycle processes, as well as different levels of staff, both clinical and administrative. As we see it, and as we have put into place, the operational steps for telehealth include, but are not limited to, choosing the right software platform, not only from a HIPAA perspective, but ones that provide the necessary features for your specific specialty. I'll use an example of a physician practice. An orthopedic service group may not pick the same telehealth platform that a primary care would. Then there's obviously identifying, purchasing, training, implementing the equipment needed, whether it's a tablet, a kiosk, additional smartphones, what have you. Then we have to figure out if the platform we're using or the platform we're going to choose gives us the ability to e-prescribe if we are a drug prescribing specialty or practice. As we choose and as we bolt on any technology, we also want to know what hiccups will there be and or will there be synergies between this platform and our already existing electronic medical record. And if we're billing either in-house or using an outsourced vendor, how that speaks to our billing modules. Also, need to know this platform that we're choosing. Are we going to use this or can we use this platform in order to bill patients for patient respective payments, co-pays, deductibles, or self-pay through this platform? Or again, does it speak to our already existing billing platform? Once we've made that decision and obviously worked out the purchasing, there's the obviously technical setup, onboarding it into the practice, bolting it onto our existing technology. We then need to move, and once we've got this technology set up, is we need to build and create workflows. We need to build and create these workflows and have documented training for both our clinical and administrative staff on utilization of this software. So there are going to be multiple workflows involved. From a clinical standpoint, the clinical workflows and actually performing the patient visit, documenting the patient visit. The revenue cycle workflows. Revenue cycle's got three major areas: front revenue cycle, middle revenue cycle, and back end. So from a revenue cycle workflow, I'll give you some examples. We've got to now put into place how we are going to schedule our telehealth visit. What does that mean for our physician calendars and blocks, timing and what have you? We've got to be able to perform eligibility for these types of visits. We've got to be able to identify as well as process our copay collection. Our providers, as I mentioned before, during or post-visit need to be able to apply the specific codes within our charge master and be able to document that this visit happened accordingly to support the billing. And then eventually being able to create, process, and follow up on a billing invoice. Another level of training that needs to happen for our providers, both physician as well as non-physician providers, our nurse practitioners and PAs, if applicable, as well as potentially for our certified coders, if we're employing them in the practice, there's got to be coding and documentation training specific to telehealth. So what does that mean for our providers, for our mid-levels, for our certified coders? Right? First and foremost, they need to understand the accepted CPT codes for telehealth. And they need to not only understand them, but understand how does that crosswalk to the specific payers that our practice credentials with and participates with. They've got to understand our providers on when and how to use these codes depending on the type of visit that they are performing. They've got to be able then to understand what is the correct and thorough documentation to support this visit and be able to support the bill that is going to go out post-visit in the event of potential post-payment audit. They've got to understand the coding utilized depending on the visit type. What is a billable code versus what is a non-billable code? And then obviously we've got to understand what does this mean for our patients who are making payments on this, either from a copay or deductible perspective for telehealth visits. There are a number of telehealth regulations as well. We advise our clients, obviously the first thing we look for is their geographic location. There is going to be specific regulations based on this geographic location on what can be provided. So understanding the mandates for telehealth in your location for reimbursement is extremely important and takes strategic planning as well as documented training and workflows. We also need to understand per our geography, what does our state mandate? Is there a parity law? Specific reimbursement for telehealth similar to your traditional in-person patient care. So due diligence on your payer mix to identify the eligibility, accepted codes, and billing practice is obviously extremely relevant and important to maintain our revenue cycle and to maintain our collection levels. Finally, once we've identified the tech, written the workflows, trained our providers and our revenue cycle staff, and are able to actually function and provide this type of service line, we next need to market. We need to market to our current patients who have had appointments already set down months ahead, who may still be affected by COVID, as well as perform outreach to potential patients and our traditional marketing outreach. So all of these things put together are areas that we have been fortunate to educate our providers and our clients on. And in some cases, to the example I gave earlier, is having to fast forward what is typically a 3 to 6 month process into 30 days in order to keep our practices afloat.
Thanks, Stephen. That's really interesting. And thank you, Bert. I mean, Stephen, I think you highlighted some of the real complexities to moving into the telehealth world in such a short time frame. Bert, what do you see as the relationship between telehealth and value-based purchasing that we keep hearing about?
Well, I see them as potentially quite critical to each other. I'm going to step back for a moment, particularly for our global colleagues who may not be familiar with that term. Value-based purchasing means pretty much what it sounds. Instead of looking simply at a piecework reimbursement model for physicians and hospitals, it starts to look at the larger question of the aggregate expenditure for the population and how effective that expenditure is. To put it in a global context, when you compare the United States to other OECD countries, the U.S. spends approximately twice as much as a percent of GDP as any other OECD country. The closest comparison, to give you some facts from 2 years ago, it was 17% of GDP in the US per capita compared to France, the next highest spender, at 11%. And yet, despite all this funding, although US hospitals are excellent and show very strong outcomes, Access to healthcare is very problematic in the U.S. For example, adults or children showing healthcare needs, their access to a doctor was the second lowest among OECD countries. This comes together when you remember that in many countries, the government actually provides the bulk of the dollars, literally more than 50% of the payments to hospitals because of programs in the U.S. like Medicare for the elderly and Medicaid for the poor. And therefore, there is tremendous pressure downward to find ways to reduce costs. Now, how all of this tie to telehealth and technology? Well, it's actually conceptually fairly simple. The scientific literature, the clinical literature, I should say, has demonstrated that an array of fairly simple interventions improves healthcare outcomes and reduces costs dramatically. So insurers, governments, and various entities that fall under the rubric of value-based purchasers are looking for ways effectively to implement these clinically recognized effective interventions. And technology, telehealth in particular, can be great support. Let me give you an example. We talk about some key cost drivers. We talk about frequent flyers, patients who keep showing up at not just the doctor's office, but the emergency room or the hospital over and over again with the same symptomology. Why is that happening? Well, clearly the system, the healthcare delivery system, isn't connecting with those patients to prevent those recurrent problems. So for chronic conditions, monitoring is key, and telehealth becomes a central tool in our ability to do that in a real-time way. Increasing arrays of devices, applications, distanced and networked provider groupings, computer algorithms work to identify who's taking their medication, what happens when they don't, what happens to a patient after they visit a hospital, is there appropriate follow-up. All of these elements are part of what we refer to broadly as value-based purchasing, and they are so adaptable or complemented by telehealth services such as monitoring of vital signs, tracking and outreach for whether patients are filling their prescriptions. If a patient isn't feeling well, a quick telehealth urgent care visit can potentially prevent an emergency room visit or, through delays, a hospitalization. Making sure that these services are comfortably utilized by physicians and support staff of physician practices or at hospitals, and that the patients can access, understand, and feel confident about the security of their information transmission are all critical aspects to bringing down the costs and delivering, in the term, value to the community or in the U.S. Stephen has been talking about how easy it is to conceptualize these things and how challenging it is to implement. Stephen, I bet you have another example.
Yes, Bert. We've had clients that either had inadequate or did not take the time out to build correct workflows to either optimize or onboard telehealth as a service. So, we had instances where our clients were booking visits that cannot happen via telehealth as telehealth visits in their practice EMR. Or they were building and scheduling telehealth visits without checking, does the provider have a procedure at that time, or is the provider's surgical block, is he leaving to go for surgery at that time? And again, improperly coordinating either within their own EMR or, as Bert said, and as I said earlier on, if there are two scheduling systems that they may have to utilize, one for traditional office visits, one for surgical visits. So again, honing back to making sure when you can that these workflows are pinpoint, that they take into consideration the correct visit types that can be functioned through a telehealth, as well as how does this work within your current non-telehealth workflows, scheduling both on either an office, in your own EMR, or outside scheduling systems that you're forced to utilize. An example would be a hospital scheduling system.
So that's a lot of changes. And as many of us know, wherever you've changed, you tend to also introduce risks, not just like what Bert and Stephen, you've been describing, but also cybersecurity type risks. So, Jerry, what is COVID-19 and the move towards telehealth meant from a cybersecurity perspective?
Yeah, thanks, Jeff. The general consensus here is really going back to what Bert and Stephen kind of alluded to with the acceleration, right? So I talk about peace of mind and around risks and opportunities as sort of the mantra. So ultimately, we have to focus on the risks first. So COVID definitely introduced a lot of risks to the healthcare industry. And I'm sure a lot of people know, but in essence, the healthcare industry is still the top industry where they're a prime hacker target. Patient information is still valuable in the marketplace for hackers, and they will continue to go after it. And they find lots of different ways to do it. Even if they're sending out portal links, for instance, as an example, as telehealth was starting to come in, and you saw the uptick. I think, Bert, you mentioned something around 8,000% increase in telehealth visits, or at least the visits that needed to be booked. That's a big increase. I know we're leveling off at this point, but ultimately, you saw hackers really coming in and trying to do more phishing attacks with their communities. And I see that with that big increase, there also needs to be more awareness with the healthcare providers. So there's general issues around monitoring, and that's what we're seeing on the data security side as well. We had a podcast that I'll re-promote with the Go Beyond Disruption series, which is this series. We did one back in a few months ago in July, where it was all about where did our data go. So ultimately, I think the challenge, the risk, is that we need to understand how that poses a threat to us, and maybe we can do something different from an awareness campaign and monitoring. You still have human error in all of this, but the other side of it, I'll talk about the opportunities. I mean, although we're moving the data constantly and continuously, I still see this whole digital health tech age now coming to an acceleration mode, changing the way these doctor visits and hospitals care for their patients. I mentioned patient engagement. Bert mentioned patient outcome. I think that's really important because when I've been working in the healthcare industry now, going on 15 plus years, what I always hear healthcare executives talk about is just that: patient safety, patient outcome. And in this particular opportunity now, you're seeing that they could actually do a lot more. I have personal experience with it, with my father, who's been ill for quite a while, helped me a lot as I care for him in terms of how I can talk to the doctor, how often I can talk to the doctors, and he has many. And even with prescription drugs and seeing the changes. So all that data now is housed in certain systems, but that's also changing as we're moving forward for the better. Now, again, take a step back and look at the risks, because ultimately, when you talk about acceleration, I think, Stephen, you mentioned it a few times, acceleration and fast forward. The complementary side of that is, yes, we have to do it. Yes, we're doing something, but take a little bit of a step back too and look at the risk, because I also see risk with third parties, fourth parties coming into play. So ultimately, we have to make sure we're doing the right thing, as I even call duty of care around what's going on. The one other thing I wanted to mention, Jeff, too, just what COVID meant for cybersecurity. This is a big deal. What I'm seeing is And the healthcare industry, although top target for hackers, has always kind of sat below or lagged behind certain other industries in terms of percentage of budget given for cybersecurity monitoring and measures and solutions. I'm seeing an uptick there, as you can imagine. Now that budget is being increased. The percentage is now close to 5% is going towards cyber. It may even go higher than that. So that's another good opportunity for, healthcare providers, even the smaller doctors' offices and practices, to start looking at this and figuring out, I have to be part of this. And by the way, the one other thing on awareness and campaigns, Stephen talked about workflows. As those workflows are changing, it's very important as you look to patient outcome and patient engagement. It's probably a good idea to get your patients involved in understanding what good security stewardship means. And I'm seeing a lot of great education going on there. And if you're not doing it, it's something to incorporate, because now as a patient, I'm seeing I can do more with telehealth and a number of other tools that I may be provided by my healthcare provider. I like the fact that I can use this information. I also want peace of mind that it's sound, safe, and my data is secure ultimately. And that's where the regulations come in. And I know, Jeff, you're going to speak a little more about HIPAA and the regulatory environment. But ultimately, those practices, as they're changing, I think if we're going to change patient outcome and patient engagement, you could actually bring them into the fold and talk about that as you're going through it.
Jerry, I mean, one of the things that strikes me always in healthcare is, and you've alluded to it, there's always a little bit of catch up, right, on the security front, and dealing with things need to be implemented, and maybe whether or not they're totally ready for prime time from a cybersecurity perspective, they may not really have a choice but to implement them, right? Telehealth may be an example of that, where whether or not they felt they were ready, they sort of had to. And I think there's a lot of examples like that in healthcare. In the environment today, too, we're obviously seeing a big uptick in the number of, third parties healthcare organizations are almost forced into using, especially as they embrace more remote technologies. How do you think all of this will affect vendor risk management over the long term?
Yeah, it's a great point, Jeff, and a great question, because ultimately I look at third and fourth party security risks in this entire environment, because there's a lot of providers out there. I mean, health tech and ultimately technology and digital transformation within the healthcare industry has been going on for quite a while, and there's more to come. A lot of dollars are being spent, billions of dollars are being spent in the healthcare industry. Bert alluded to some of the stats that just here in the U.S., and we do feel like it's going to increase in terms of how much health tech will be out there. So we're going to have more third and fourth parties coming into play. So the fourth party, just so everybody knows, is the actual provider of that third party that you may be using. And do we know who they are? But ultimately, I go back to a concept that I think really provides our clients, our healthcare clients, with a good, sound way to look at this. When you're looking at a third party, as you're getting into that acceleration mode, because you're right, Jeff, they had to provide these services to their patients. Again, if they're focused on patient outcome and patient engagement, this was the only way to engage with the patient. So it was very important for them to accelerate that. At the same time, did we measure what we did? So I talk about 3 M's in cybersecurity and information security. There's measurement, there's management, and there's monitoring. So ultimately, with the third and fourth parties, if we focus just on the third, did we measure how we actually accelerated that adoption of a telehealth portal, a telehealth tool, whatever it may be? A lot of things in the workflow that Stephen was talking about, a lot of those were new. And instead of a 6-month engagement, a 6-month implementation, you truncated it maybe in 30, 45 days. So ultimately, put the risk hat on and understand how we measured what we did and ultimately where we're going, because there will still be changes in those systems. And then how you managed it ultimately at the time when you implemented, and then on an ongoing basis. So the management of the controls and the processes within that workflow with that third party, they need to be responsible for giving you data where you could measure, and be open and honest with them about your practices on what you're going to do. So there's a lot of good vendor risk management programs out there that have those 3 M's embedded. And the monitoring, to me, is the biggest piece, because that's where a lot of healthcare providers fall down in terms of third parties. I think they just lack the expertise and the controls potentially to perform the monitoring the way they want to do it. So ultimately, look at that as a way of you controlling it and share with the provider what you're going to do. And they ultimately may embrace it. I've seen that more than the other side where they don't. And you want to show them that you're good stewards for all the things that you want to do to get to that ultimate patient outcome, patient engagement. So there's many different ways that you could look at vendor risk management, but ultimately focus on those 3 M's.
Thanks, Jerry. That's some really good perspectives, especially as we think about vendors and security, because I think that is often a tough area for many healthcare organizations. Shifting into the regulatory landscape, it's interesting. I think some of the regulatory risk is a little bit all over the map right now, just because regulators haven't necessarily caught up with enforcement and monitoring some of these areas. Or in some cases, regulators have stated they're going to back off a little bit in this time of big change. But as we all know, typically regulators don't stay out of the mix forever. They eventually come back into the fold. If you're familiar with HIPAA, for example, the Health and Human Services Office of Civil Rights, which is the U.S. federal agency tasked with HIPAA enforcement, announced a couple months ago that they're going to utilize discretion in how they enforce HIPAA around a number of areas surrounding telehealth and the different packages used. And that sounds great, right? And similarly, a lot of payers, health insurers are actually subject to a number of data security standards, and they've adopted telemedicine. But so you look at OCR coming out and talking about, having that discretion in enforcing HIPAA. You do have to take a step back and say, okay, well, if you utilize some of those sort of outs, right, in fully complying, how long will those things stay around? So, for example, let's say you're using some of these telehealth tools and because you were in a rush, you didn't get the business associate agreements executed, which is a requirement of HIPAA, or you didn't have a chance to do a security risk analysis around those tools before you started using them. I think what the regulators have broadcast is they're probably not going to go too heavy on you in the short term from an enforcement perspective. However, as that's become more of the norm, and I think as you've heard, as Bert and Stephen very astutely pointed out, and Jerry layered on with the security aspects, if this becomes more of the norm, I think you're going to see the regulatory bodies have an expectation that the same level of security that maybe you would apply to in-person visits needs to be applied to those remote visits, maybe even more so. So there's really an interesting dynamic going on right now where while enforcement may be by the regulators may be down a little, we may see a big uptick as this becomes the norm and potentially as we start seeing some breaches through these different avenues, it's probably going to increase the enforcement there. So I know we recommend to a lot of our clients, don't wait and just say, well, hey, we had to use this tool, so it is what it is. If it's you had to use the tool, it is what it is. That may be okay in the short term, but you still need to go back. And Jerry, I think you really highlighted it well and really assess those risks and think about, are you doing everything in compliance with HIPAA or state data privacy laws or whatever other regulations apply to you in the health data space to make sure you do have things buttoned up and you've looked at the controls and that you have the right security in place. So Bert, Stephen, and Jerry, any other concluding thoughts you wanted to hit?
Indeed, I think we have covered a great deal of ground here. In particular, I think we have highlighted the intersection between policy, operations, and technology, much U.S. specific, but much general as well. In creating a framework for all of our clients, we propose thinking about extensions or accelerations of existing technology versus discontinuities and demand for new thinking. An example of an extension would be telehealth. Although it's accelerated and we are at a point of inflection where now telehealth is a core component of healthcare delivery, especially we think in the universe of monitoring patients, we will need to guide clients in adopting long-term strategies to manage that information securely and integrate it effectively for decision-making. Conversely, a real discontinuity comes in the arena of value-based purchasing and its requirements for data analysis. Currently, there is inconsistency in systems. As Stephen mentioned, often one provider and the next will not even have the same EMR. Or in the case of a hospital system, information will not be resident in a common database, and the systems capturing it could be not interoperable. Therefore, we will be relying more on technology and technology vendors to bring together this information, allowing us to more effectively manage the health of populations. That, of course, creates new issues around data management, manipulation, security, and compliance with requirements around it. I think Jerry's point about the 3 M's will be critical in thinking how to approach these new challenges.
Stephen, any concluding thoughts?
Yeah, I think what we all kind of touched upon is prepared and readiness, right? So, every practice is different. In some cases, we've seen telemedicine. We've had, preferences by our practice to focus more on telemedicine to potentially reduce brick and mortar and improve costs. We have practices that currently still rely on telemedicine in order to remain afloat. What we think is going to happen down the road is that there has definitely been some leniency from the payers, and that there is going to be definitely a lot of focus, probably starting with the governmental, and then as typical, followed up in short order by the commercial payers on auditing telemedicine. Typically, we have seen audits kick off from anywhere from just high volume. If a practice has a high volume, they're doing everything correctly. They automatically raise a flag when a payer sees we are getting X number of claims coming from this tax ID number per month. Let's make sure they're doing everything okay. In this instance, everybody knows that COVID is out there. Everybody knows that we've had to switch to telemedicine. In some, for some specialties more than others. So we think this is a ripe opportunity for the recovery audit contractors to go in and start picking apart practices who provided telehealth services as an opportunity to see what dollars they can in fact recoup. So while we have to put telehealth in either for survival, as a supplemental service line, preparedness and being able to self-audit is huge. So we are recommending to our clients that this is a perfect time to take a pause and do a coding and documentation assessment. How are our providers documenting? Is it supporting the bills? Are we selecting the right codes? Are they billing for visits that are in fact billable and not billing for visits or using incorrect codes for, say, post-surgical visits that are typically not billable? So now is a good time to get out ahead, prepare yourself, because we think that these audits are definitely coming down the pike.
Thanks, Stephen. Jerry, any other concluding thoughts?
Yeah, I think from a standpoint of where Stephen was just going, I think that's very important. So preparedness and readiness, very key. So from an operational standpoint, Stephen really articulated a lot of different areas, and even Bert from a strategic standpoint, a lot of different areas that you could focus on. Do the same from a cybersecurity standpoint. Preparedness and readiness. So there's a duty of care that you have to have. So review your security program to ensure it's comprehensive and can stand the test of time. As we sit here going into a new age, be agile and resilient, and ultimately build awareness around you to combat many of the existing and emerging security concerns that we do see. And it continues, right? You have to stay on top of it, but ultimately get prepared to be in that so-called duty of care. And I focus, and I don't want to discount security awareness training. It's the most important on the people side. You could teach your staff how to identify, avoid, and report attacks that are happening as they occur. And you could even do the same with your patients, as I mentioned. As they're getting into this new age with you and taking that journey, take a step back, bring them along with you. So it comes full circle.
Thanks, Jerry. Great point. Thanks to our panel, Bert Orlov, Steve Bisciello, and Jerry Ravi from Eisner Amper. You can connect with them via their LinkedIn profiles, which we'll link to in our show notes. To view those show notes, just use the podcast app on your smartphone or tablet, or open the episode in your computer's web browser. You'll find everything right there. From Baker Tilly, US, I'm Jeff Krull. We'll be back soon with more conversations that help you and your profession to go beyond disruption. Till next time, keep listening and goodbye.
Thanks for listening to this episode of Beyond Disruption, brought to you by the Association of International Certified Professional Accountants. Learn more about today's topic at AICPA-CIMA.com/disruption. This podcast is designed to provide illustrative information with respect to the subject matter covered and does not represent an official opinion or position of the Association of International Certified Professional Accountants or any of its subsidiaries or affiliates. It is provided with the understanding that the association, its affiliates, and subsidiaries are not engaged in rendering legal, accounting, or other professional services. If such advice or expert assistance is required, the services of a competent professional person should be sought. The association, its subsidiaries, and affiliates make no representations, warranties, or guarantees as to and assume no responsibility for the content or application of the material contained herein and expressly disclaim all liability for such damages arising out of the use of, reference to, or reliance on such material.